right. So we are back again. We're on a roll today, guys. So I hope you guys are ready to learn. See how much you can get through in a day. So menstrual cycle pain and premenstrual syndrome. So let's get into this discussion topic. Move my little down at the bottom. All right. Premenstrual syndrome. Not much to say about that. I kind of look at you like, normal symptoms, sometimes pathologized. How do you say that word?
Pathologized.
That sounds good. Yep. So serious mental health condition might be misdiagnosed as premenstrual syndrome.
So I do see this in the office, and usually the way you can kind of narrow down is this cyclic? Does it occur right before or the week of their period? And do they have symptoms of severe depression during this time? Or is it just irritability, fatigue, hot flashes, moodiness? They describe it in different ways. But PMS is really a real thing. A lot of women do respond to the hormonal fluctuations.
Okay. So scope and prevalence of the problem. So dysmenorrhea, significant menstrual pain, often debilitating. Would you agree? Do you see a lot of patients with dysmenorrhea?
And many times it's the adolescents that they're missing school, they're missing work. It's every month. They may be throwing up, they may have diarrhea, they may be laying in bed with a heating pad on them. So yeah, there is that. That would be debilitating and just
100%.
Right, absolutely. But then there's some women that they'll go, yeah, I have cramping, and because the only person that they know that has their period pain is themselves. So defining how bad it is for them is each individualized.
Right. So painful cramps that occur with menstruation, right, affects 90% of women. And that's exactly what Terry's just said: diarrhea, nausea, vomiting, diaphoresis, fatigue, headache, and sleep disorders. And there's that pain. And that's usually due to that uterine contracting during that menstrual phase. Anything we need to add here with this, Terry? I know there's risk factors. Y'all can look at the boxes. There's primary and secondary. So we'll go into primary. Usually this is kind of like the onset of their menses, right?
Exactly.
Because they've never felt this before. So everything's new to them, right? And we have to listen to what they're feeling and have some sort of empathy with what they're going through, of course. So symptoms within the early set of whenever they start their menses, right? Okay.
And this can be as early as an 8-year-old. Unfortunately.
It's getting younger and younger. I think, honestly, I think so as well. So there's secondary, and it's caused by pelvic pathology.
Exactly.
So this is kind of later on, essentially, and we see that in endometriosis for sure. Right?
And uterine fibroids are another one that comes a little bit later in their menstrual life.
Right. Yep. So how do we manage these patients? Non-pharmacological, we always go for heat, right?
Yeah.
Heat.
Yeah.
And so what about exercise, avoiding smoking, avoiding those or limiting soda and sugary foods, managing the stress level? And here's some vitamin herbal treatments, the E and omega-3s.
Yeah. People ask me about, well, should I take this something herbal? And, it's not going to hurt anything if they find improvement about that, or is it a placebo effect? But certainly that's okay. A lot of the pharmacological, they find we use a lot of NSAIDs first line, birth control pills. And then the progestin products are the without the estrogen, and it is a type of hormone, but it works it can work well in controlling the painful periods. So that comes in pill forms of the intradermal. We use a lot of Nexplanon. That is, they don't even have to be sexually active. That is a great method of controlling their periods. Now, I'm going to say something about the Nexplanon. We use a lot of those. They're good for 3 years. They're great birth control method. But what it does is it thins the lining of the uterus. So therefore, it will help with the heavy bleeding, help with the painful bleeding. But one thing I have to caution patients about is it can produce unpredictable bleeding. That's the #1 side effect. And they just need to be aware of that. It does lighten and lessen how much they're bleeding. That's been proven. So I've never found anybody, I could say never, never found anybody that was anemic because of the bleeding they experienced after the Nexplanon was inserted, but they feel like they're bleeding more because of the unpredictable bleeding they experience. The levonorgestrel, the progestin IUDs, we have 3 of those available. The Scala with the least amount of the hormone, the Kyleena, and the Mirena. Mirena has been around the longest, and that's the most effective because it has more of the progestin in it that's absorbed directly into the uterine lining. So that's a great method to control the painful periods. Depot, that's the injections. I use like cautiously, but it actually works really well to control pain because more that we use it or longer that we use it, the less bleeding they have with that.
Wow.
Yeah. The biggest side effect on that one is weight gain. And it's pretty much that's across the board. Particularly if you've got a fluffy person, they're going to gain even more. So you have to really watch.
Be cautious.
Yeah, be cautious of that. The other person I would not use that in first line would be a teenager with bone growth because it can decrease they can have some bone loss, but that's reversible once you stop the depot. And then surgical interventions. Yeah, they're not going to do a hysterectomy for dysmenorrhea typically.
Let's hope. So then we kind of go into, we talked about premenstrual syndrome, and then we go into the premenstrual dysphoric disorder, PMDD. Do you ever see much of
I
this?
do.
Okay.
I do see it. Less PMDD, but it is out there. I saw one this week that I think she truly has PMDD.
Oh, wow.
Yeah.
Okay.
So she gets in a deep, dark depression about 3 days a month with PMS. It is, with her PMDD, it is cyclic. The problem that I had with her, she already has some psychological problems and sees a psychiatrist.
So how old is this patient, can I ask?
I think she's 23, 24.
Okay.
I think.
So we're out of the adolescence, more young woman. Okay. Yeah. Just curious. I was just, okay. But she does have some underlying comorbidity of psychological.
And so, I think I ended up putting her on, I can't tell you the dose. Anyway, I put her on the generic gas.
Okay.
Because that has been FDA approved for PMDD
awesome.
treatment.
Look at that.
Yeah.
All right. So there's an incidence. You guys can read those and the percentages that accompany that. Here's the differentiation of both of these. So y'all can read on that. I don't think there's anything we can add to that. Of course, just what Terry said, explore what's normal and acceptable for each woman. I guess you have to kind of differentiate, especially with comorbidities, as she kind of pointed out. If we're going to totally diagnose this person, then we need to look at every little.
Yeah, even with you think that as the woman gets older, she's got more problems that you have to deal with and consider. But even the younger women, particularly if they have psychological problems and mental disorders, that you have to consider as well.
Right. And I love that. Clinicians should also provide care that's individualized, woman-centered, and evidence-based. And I think we all can agree with that for sure. So the goal, here we are, understand their premenstrual experience, what it is to them, how they
Exactly.
define that, and how do we manage those symptoms and any kind of associated problems that surround that issue.
How much school are they missing? How many days of work are they missing each month? And then they may say, I'm not missing, but I certainly, my quality of life during those days are terrible.
Of course, you need to get that as their chief complaint. You need to be
Yeah.
asking those pertinent questions, right, that surround
Absolutely.
that, because we need to know how to treat it. And there it is, daily record of severity of problems. Just like you said, you found out that the one girl that you were treating, it happens 3 days before
Mhm.
she starts her period.
Mhm.
So you got that because of that, that discussion.
And
with
there's a
her.
lot of apps. There's a lot of period apps.
Thank
We
you.
didn't have those. When I
No.
was- but now it makes it easy.
I'm always like,
and-
when was your last period? I don't know. I have no idea. And now there's an app for that.
Yes,
Of course,
exactly.
y'all are so lucky. All these younger generations are so lucky that there's an
I
app
learned
for
a
that.
lot from my patients.
Seriously. And of course, there's no specific test, right? This is basically history and physical, right? So here we are, differential diagnosis, and we have to figure out, we have to track on pattern severity of symptoms, distinguish from any other issue, just like she said, she had that that patient had a psychiatric comorbidity, essentially. Is there
Well,
endocrine?
Yeah, absolutely there is. But back to where you say, is it a psychological problem or is it cyclic? A lot of women will come in, well, these birth control pills make me moody. And so that, you have to figure out, is it truly making a moody or is it other things and it's not related to the pills?
Yeah,
So
true.
that's
so true.
yeah, so it's
So you have to be able to differentiate what they're talking about.
and the
right?
more history you get, the more questions that you ask, you should be able to, in most cases, figure that out.
I think that's
Yeah.
important, is the questions that we do ask, So assessment can be therapeutic, just what we talked about. Have you asked them the right questions? Are we getting the information? Especially if you have that rapport with the patient, you're going to get more out of them, and validating those symptoms. And there's some elements that form a therapeutic response. I think we're all good at that because we're nurses.
Mhm.
And I hate to put that out there, but I think that's kind of true.
Yes.
Therapeutic options. So you guys can see that we combine self-care, social support, medical therapy, psychosocial strategies
Mhm.
as well. Do they have the balanced diet? Are they
Yeah.
eating good, sleeping well, exercising? Anything you want to add there?
No, I mean, we do use the SERMs, we do, or not the SERMs, the SSRIs, we do use those. Particularly, we use the old fluoxetine.
Yep.
Prozac.
Yep.
We use that quite a
glad you
bit
know your
because of the
generics.
long half-life. You can use that cyclic to where you use it the week before their symptoms start and the week of their symptoms, and then they only have to use it for 2 weeks. So somebody that's adamant about not wanting to take something daily, if they have a regular cycle and they want to use that's something they, in fact, they used to package it as Seraphim. So the company actually had 2 weeks a month that you could take fluoxetine, but it was so much cheaper to prescribe
Right it.
Prozac.
Yeah. Look at that. That is so
Now, I
funny.
don't find that as well as the other SSRIs don't work quite as well. They can, but that's a good go-to. Yes.
How do you feel about oral contraceptive pills for these
It
patients?
works.
It works.
It works
Yep.
because it keeps their hormone
Hormonal
level
balance.
steady.
Hormonal balance is
Yeah.
so important, for sure. I could see that. I don't know what your feelings about some anxiety medication there.
No,
but
I don't.
I
I
would-
stay away from
yeah.
that.
I would not even dip
Yeah.
in that. I don't think.
Diuretics, I don't do that either. It just, you don't want to get into dealing with their electrolytes and but as far as these non pharmacological, I can't stress enough water and no caffeine.
Yeah, we were just talking
Yeah.
about that. You know, we
Oh.
had to go fill up our water bottles, so we're preaching drink water. So we were like, we have to do the same thing. Okay,
I'm a fan of caffeine in my own diet, but I do limit it.
1 cup a day.
Yeah, I do
One
limit
cup.
it, but if they are drinking nothing but caffeine through the day, you put hormonal imbalance on this on top of it, and they're, no wonder they're feeling the way they are.
Right.
But sleep, exercise, and decreased caffeine.
100% over.
It can make a difference in how they relate to the
Yep.
PMS.
100%. So this last slide was just a duplicate. So forgive me because I was just doing the slides and I kind of combined this so I could squish it together. So let's keep going. That was a great topic, So let's share my next slide. So now we're going to get into normal and abnormal uterine bleeding. So oh, and now we're getting all fancy with the PowerPoints. Look, I got really fancy with those. All righty. So what can we talk about with this? What is it? Abnormal uterine bleeding, out of the ordinary for the woman. So basically we have to know what's normal, right?
Exactly.
To find out what's abnormal. So we see what that looks like. Let's see. Here we go. Normal menses. So we know that there's that hypothalamic pituitary ovarian axis, right? So the
Right.
hormones that leads to ovulation,
With the feedback and the cycles.
Yep, the feedback loop that goes back.
Exactly.
Of course, normal menses, it varies, right? And that's
Mhm.
such an important factor for an assessment with your patient. And whenever you're getting that from the patient, you want to ask how long does your period last, right?
Well, I want to know first off how regular they are, because you may have somebody that's every 24 days and they'll go, find out how they count their days. Because if they count day 1 as the start of their period or at the end of their period, I'm still bleeding.
Yeah.
So, yeah. So, I count day 1 until the day before they start their next period. That's the length of the cycle. Okay. So that's important because they don't always count that way.
Onset to onset.
Yeah, onset to onset.
Okay.
Exactly.
Kinda like
That's the
counting
length of the
contractions.
period. So even as nurses, sometimes we don't get this because they teach us 28-day cycles. For those people, which is not every day, every 28-day cycles, excuse me, it may be, they may have 24-day cycles.
Right.
They may have 35-day cycles. So that's important to know. That they say, oh, it doesn't come the same day every month. Well, no, because every month may have, one month may have 28, the other month may have 31.
Like
So no,
February,
it's not
right now.
It's not going to happen on the 5th of every month. They have to understand that. So that's where the period apps come in, and they can figure out how many days are their cycles. So what's acceptable is over 21 days. You don't want anybody bleeding more than 21 days, okay? Because then you are risking that they'll become anemic because they come too often. So average is 24 to 28 days, but it's acceptable over that. Some women may not have a period at every 35 days, 42 days. So that's still acceptable.
Right.
So,
And we're not including those that are in there who may have some sort of contraception.
no,
Right. So we
right.
gotta
So
make
birth
sure.
control pills, yeah, that's a different, because
Right.
that should be a 28-day cycle
Right.
for most people.
Right.
Yeah.
Or those that go without periods because they're on some sort of birth control.
Exactly. That
Yeah.
excludes this.
So
This
all
is
of
just the
that.
woman who's not on any kind of hormone, and you're trying to find out what her menstrual history includes. And then you want to know how many. So my usual questions were, are your periods regular? They tell me how often you're having a period. How long are your periods? So from the start to the finish. Okay, you may hear, I may have a period for 5 days. then I'll spot for 2 more days. So your period lasts about a week. Is that what you're saying? Yes, my period lasts about a week. How many days are you heavy? What's your heaviest days? Oh, usually it'll be real heavy on the second and third day. You'll hear such examples. And then so that's how I'll describe it in my note. Period is regular. It lasts about 5 to 7 days and heavy for 2 to 3, painful for the first 2 to 3, 4 days. That's how I
So
describe my menstrual
what about
cycles.
like pad uses or tampon?
You can get into that because that varies from person to person. So if you got somebody who's saturating a pad or tampon every hour for several days, you're talking really heavy bleeding.
Oh, yeah.
Yeah. And more women are using the period cup. So that is also included in that assessment whenever you're talking about the pads, tampons, or the period cups or period panties.
Right.
Yeah. So
Wow.
it's becoming more popular.
All right. So we know about kind of the cycle. I think you guys kind of understand that the regular ovulatory menstrual cycle, withdrawal progesterone causes that arachidonic acid, which accumulates the production of PGF2 alpha, which causes dysmenorrhea, right? So now we get into the abnormal. So we know what normal is. So whenever you get patients who come in that have abnormal uterine bleeding, then that's kind of where things kind of change, right?
Yeah, exactly.
So it can be from no period to a heavy menstrual bleeding. So it's irregular in amount, frequency, duration, and even timing. So it may or may not be related to the menstrual cycle, right?
And like I say, you may have somebody that comes in and they're having a period once every 3 weeks. That is when you need to treat or find out what's going on and treat that so that you don't risk the risk of anemia.
Right. So there's a nomenclature. We found this kind of cool that they have the POM and then the COEIN, COEIN. So that's kind of unique, and it kind of breaks it down on over. So we'll keep going. So the evaluation, what information are we going to get? And it says it should be guided by the POM and COEIN classification system. Always get a great medical history. What's your normal? You know,
and
what
that's
does that
one
look
thing
like?
I ask, because they'll say, I've been having my period and I've been bleeding every 2 weeks. Okay, well, let's start with normal. What was it 6 months ago?
Yeah.
What was your period? What's the norm for your period? And then you get into, well, when did this start that you're bleeding every 2 weeks?
Right. It's so important to kind of pick up how long has it been abnormal for, right? And there's that menstruation and contraceptive history, age. When did your menses start, right?
Exactly.
And she's already went through all of that. Yeah. Contraceptive. Do you use any? We need to know that, especially if it's a patient you haven't seen yet too. You may have it in their chart otherwise, but you always need to talk about it.
And, when you're looking at that and they're not using contraceptive method, like a hormonal contraceptive method, you want to think about pregnancy. Is that because they think that they still having periods?
It's true.
You need to find out if they're pregnant or not.
And that happened to me. I was on the pill, same thing, did not miss the period, had like bleeding, thought everything was fine, had no idea I was pregnant. It was like a shocker. So
even a 50-year-old.
See, don't go there.
Yeah.
Not gonna happen.
So cover yourself and get a P test.
There you go. There you go. So we always have to determine the causes. What about endocrine? You talked about this too, and I know it's coming in the laboratory evaluation, but you always have to think there could be a potential endocrine issue, right?
There can be. So like with somebody who is not having regular periods, we call it an amenorrhea panel. And we'll think about these certain hormones, thyroid, prolactin. So yeah, you have to take that in consideration as well. I think that's where the COEIN comes in.
Yeah, exactly. You should always roll out pregnancy. There it is. She talked about it and it comes up. Imagine that. Like, she knows what she's talking about. So objective. Of course, we always do our physical examination. Would you agree with that? Pelvic, speculum, bimanual? Do you go there?
Absolutely. I do. The bimanual is important. Not only you may not feel, but you can also assess if they're tender. Are they, because I will check a lady who, I'll say, I just want to see where you're tender, because she'll say, I'm having pain. So,
Mhm.
okay, well, let me find out where that pain is. So I'll touch her bladder. And I was like, you've got to pee, don't you? Yes, that's, sometimes you, sometimes if they are really, there's a UTI,
Yeah.
they're very, very
Oh,
tender.
I'm
or-
sure.
yeah. But anyway, or the uterus, or as well as the nuts and the ovaries. So yeah, the
Exactly.
bimanual comes into play with that.
Exactly. Here's our laboratory
Mhm.
tests. I know there's a table in your book that does a really good job kind of like laying these
Really
out.
good,
Is there
yeah.
anything here that you would say, Terry, that you may or just may not get when you have abnormal uterine bleeding with patients?
So all of these, well, let me tell you what I would first do. I'm going to look for anemia and pregnancy. And if oftentimes they're in my office, but they might have a primary care, and I want to ask them, have you had your thyroid checked, your function checked recently? And they may not know, or they're not sure. Go ahead and cover yourself and do a TSH. Prolactin level comes very important if they're not having periods regularly. Or even with breast nipple discharge, I'm going to run a prolactin level on them. And then you're looking for vaginitis,
Yeah.
vaginitis or STDs. And it's a hard question, but even with a married woman, you may not know what's going on in that relationship. So if she comes into me and she's saying, I'm having bleeding every 2 weeks, how long has that been going on? Past 6-8 weeks. Is there any reason to check you for STDs? I kind of put it that way because if I say, well, we need to check you for STDs, they're going to get very offended, particularly if their relationship with their husband is in a good place.
Right. Monogamous.
But sometimes you find out it's not in a good place and they didn't want to share that with you because they're embarrassed. So yes, think about STDs. So I think about make sure they're not anemic. Think about endocrine, think about infection, and then anatomical.
Perfect.
So
Perfect. Yeah.
That's kind of where
I think it's important. And here's some more differentials.
One last thing, this
Yeah.
coagulation, that's very important too, to consider possible von Willebrand's disease.
Yeah.
Or syndrome. I don't think.
Yeah.
That's really important to know, particularly when you're dealing with somebody who's bleeding a lot.
Bleeding disorders, anything like that, you want to make sure they don't have any kind of history there or something that underlying that maybe hasn't been picked up yet.
Yeah.
So differential diagnosis, what do you see there as far as differentials? I think you kind of talked about it. It's in the table 26.
That palm, that's perfect.
On the next slide.
Next slide over. That's
there's your
that's where
differentials.
I'm going whenever I'm looking at that. I do see a lot of polyps. Okay, so that sometimes takes process of elimination. You sometimes can see a polyp on an ultrasound, but sometimes you have to get that ultrasound. You may see a thickened lining and you have to get them back for a saline ultrasound to be able to make that diagnosis of a polyp, an endometrial polyp, endocervical or endometrial.
Right.
Adenomyosis also is one of those process of elimination. You may not see that first off on the ultrasound, but a gynecologist who is well versed in this, they sometimes can see the look by reading the ultrasound that they can see evidence of the adenomyosis. Uterine fibroids are very, very common. We can even see them in 20-year-olds.
Oh, wow.
Not as common in the younger women, but certainly I've seen young women with fibroids, which is kind of a shame because, for instance, I diagnosed a 31-year-old nulliparous, not in a relationship, that with uterine fibroids. And so because of that, and it's unusual, she's got some large fibroids. I'm going to try to save her future fertility and refer her to a reproductive specialist. And so I sent her to Charlotte for to consider surgical removal of those fibroids.
Wow.
So that she can have a baby later
Yeah,
on.
of course.
And then, of course,
Can't
malignancy.
forget malignancy
You
or
can't.
hyperplasia.
You know, typical is not a real young person. There, I don't have an age group, but if you've got somebody who's 35, she's carried a lot of weight over the years, I would certainly not hesitate to do an endometrial biopsy to find out if there's some cancer cells.
Right.
But definitely on some woman who is at 50, may have not gone through menopause yet, or your postmenopausal woman after 60, she's at high risk for uterine cancer.
Oh, yeah, for sure. And here's that COEIN,
Mhm.
non-structural abnormality. So of course we have to look at it. Do they have a clotting disorder? You know, have they been tested for that? Ovulatory dysfunction, endometrial.
Mhm.
So anything there?
We see
Just
all
can't
of
forget it.
those.
Yep, can't forget it.
Yeah.
And I think since we've talked about that, I'm gonna go back to this slide and kind of hit up on diagnostic tests.
Yeah.
How do you feel about, so we've talked about the differentials because that kind of skipped ahead,
Right,
I know,
right.
but the transvaginal ultrasound, endometrial biopsy.
Well,
What's your
talking with
thoughts?
Michelle, we do a lot of ultrasounds in our office, and your information will say transvaginal or pelvic sonography, same thing. So if you want to cover your bases, you just order a complete ultrasound, and that way you got everything you need to be seen. Now, we have a lot of referrals in for like ER visits. They've got somebody with pelvic pain. I don't get them off subject, but I want to say this: they had a CT scan, and they may have been looking for appendicitis or say a kidney stone because of the pain, and they happened to see something on the CT scan of the pelvis.
Yeah.
They'll see maybe a cyst or a possibility of a uterine fibroid. To be more diagnostic in this area, I'm going to get a pelvic ultrasound. So that's more diagnostic for my purposes rather than a CT scan or MRI.
Perfect.
Okay.
Perfect. So that makes sense.
Okay. So ultrasounds, like I say, we do a lot of them. Endometrial biopsies, I may do 2 or 3 a week in my practice to rule out carcinoma.
Wow.
Yeah. Hysteroscopy is something that I'm not going to do, but a gynecologist can do, and we can actually do those in the office under sedation, which we do quite frequently, at least once, twice a month.
Wow.
An MRI and a CT, I'm not using them as often to diagnose this. Definitely not an MRI. A CT scan, not so much for ruling out bleeding, but whenever we get to pain, and if I didn't have find any pathology on a ultrasound, we'll go to a CT scan next.
Perfect. So definitely a complete
ultrasound.
Ultrasound. Yeah, that makes a lot of sense. So now we can see special considerations. So trauma, right? Sexual assault. We cannot, it's kind of like the elephant in the room, so to speak. We've got to ask these questions no matter how hard they are at some point.
Tampon usage. Not well, I've got to tell you something special. Tampon, I think it makes their life much better. I encourage them to use tampons if they're comfortable with it. Just change them
Right,
often.
I was about to say,
Yeah, change them
out.
often. But I want to tell you, women forget them.
They do.
And they come in and I've had this light discharge that smells. So we do an exam. And there's a left tampon
up there.
Oh my goodness.
My preceptor said that happened to her.
And it happens.
Yes.
And they're so embarrassed they could die. But we see it, we remove it, we put them in a plastic bag so nobody else smells it. But thank God for masks.
I was saying the same thing.
Yeah, thank God for masks, because it is a raunchy smell.
I cannot.
But
imagine.
it happens more than the other.
Yes, I'm sure. I'm sure. Management. So how do we fix these patients? So of course, we're trying to fix their bleeding. What's your thoughts surrounding management for these patients who have abnormal uterine bleeding?
Well, you're going to try to find that works best for their lifestyle, because if I go to, let me give it if I'm trying to get a teenager who has heavy periods, but she's not going to take a daily birth control pills, that's not going to be a good option for treatment for her.
Right.
Somebody who, I see quite a few college students that come in, they're on a sports team, and that's their life. We may look at something like the Nexplanon to control their bleeding right over NSAIDs or birth control pills. So you need to look and see what their lifestyle is. So, and there's a number of ways of treating. I choose birth control pills for a lot of women because that's acceptable way of controlling. Plus, it kind of kills two birds with one stone. They're sexually active, so I keep them from getting pregnant as well. So combined oral contraception, progestin. That's not the first thing I'm going to choose for a younger woman, just mainly because the progestin only contraception that can also treat that heavy bleeding is not going to do as good of a job as the combined. It's just not. But there's several therapies with contraception. So I have a young girl that comes in, mother brings her in, and she's missing school because of the pain. She's bleeding through her clothes at school. One of the first things, if mom can help her, use a birth control pill. That's one of the things that I'm going to manage her bleeding with. But she's worried that her friends will find out that she's on birth control pills. Don't tell them.
Right.
Don't tell them. They don't need to know this. We use this for so many more because there's so many benefits of birth control pills than to prevent pregnancy. Exactly. So yeah. So anyway.
Unreal.
Yeah. So hormonal control is one of the easiest ways to do it, because it is and there's different ones. There's a lot of them. Estrogen therapy, I don't so much. If I'm going to give them estrogen, I'm going to give them through the birth control pills, unless there's a reason why I can't.
Right.
Yeah.
Right. So non-hormonal pharmacological management. So number one. You see how she says that quick.
Mm-hmm.
And then there's that new
and that's accepted too, because somebody who's really I've tried birth control pills, I don't want to use that. So I'll say, I don't want to take a pill every day. That is, so they can use that. I tell them, okay, have you ever considered using ibuprofen or a leaf? Now, I'm not asking you to use those. I'm asking you to let me prescribe this, which is a little stronger than what you can get over the counter, so we can manage your painful and heavy periods. So if you start, say, naproxen 500 milligrams on the night before you know you're going to start your period, you can control that. If you take that every 12 hours for the first 2 to 3 days, you can lighten how much you're bleeding and control the pain. Oh, I like that, because that way I don't have to take something every day, and I can be in control.
Control it.
And
100%.
certainly you're going to take your precautions with your NSAIDs to, take with food and that kind of thing.
Right.
So
yeah, of course. And what about Laceta?
Okay, so that has been that was apparently used for free bleeders in the dental office for dental procedures, but has been FDA approved in later years to use to control bleeding. So we do use that. They take it only for 5 days. They start it with the first day of their period, and they take it every 8 hours or 3 times a day. For 5 days, and that can be used for control of the menstrual bleeding.
Perfect. So here's surgical management. Do you see going there a lot with your patients? Do you feel like that the other
Not-
stuff helps?
Yes, this is great for your women who no longer wants children. If they have considered, no, I don't want any more children. Yes, endometrial ablation, we use it a lot. So women are tired of their periods. They may not want to be on birth control. Say their husband's had a vasectomy. They have heavy bleeding every month. They have 10 more years or so before they have ever stopped their periods with menopause. This is perfect because how it works is it is considered a surgical procedure, but it's the least invasive. They're put under some anesthesia and their cervix is dilated. And it's a technique that cauterizes the lining of the uterus. The technique that we use, that most all of the surgeons love it. And it's 85 to 90% effective. If a person is a candidate for it, they can do it in the office under sedation. It only takes 90 seconds. Their downtime is they can go back to work the next day.
Wow, that's unreal.
So that's why that we use that a whole lot for somebody who is no longer worried about their childbearing.
Okay.
Yeah.
All righty. Of course, last but not
Uterine
least.
artery embolization's not done in our office, but it can be done. And I don't know so much of our surgeons are doing this, but there is in the area vascular surgeons that we can refer to. We've referred to Catawba for embolization of fibroids.
Kind of makes sense, doesn't it? If you think about it.
Yeah, and it works. So I have a lady who is late 30s, can't remember exactly, late 30s. She's holistic approach. She don't want to take hormones. Besides that, she has a history of the uterine fibroids and they're big. I can feel them on her. And the birth control pills she did well with for a long time, but they were growing. And so she liked the idea of the embolization and she has done great.
Wow.
Mm-hmm.
That's unbelievable. At least
yeah, hysterectomy.
have to talk about it.
Hysterectomy is still done and
Yeah.
it's still done fairly often, but that's not our first line.
Right.
If we can't satisfy this bleeding by these other means, by an IUD, by the endometrial ablation, by the fibroids, if that's not the problem, then hysterectomy and they no longer want children. That's
Right.
certainly, that does not mean we're taking their ovaries. It's just the uterus.
Right. Right.
And now the approach is either robotics or they do the laparoscopic assisted vaginal hysterectomy. So they're doing a lot of that, cuts down on some of the downtime.
That's awesome. It's so much less invasive than it was way back when.
Absolutely.
You know, alternative treatments. Of course, it says more research is needed. There's studies out there, but not much there. So we won't even touch that. So diagnosis and management of amenorrhea. So we're flipping lids here just a little bit. So bimanual exam.
Yeah, because I have found imperforate hymen before.
Really?
Because the primary care had not even looked.
Wow.
The pediatrics hadn't even looked. It's a tough subject, but or even a partially perforated hymen.
Wow.
Yeah, so that's important.
Yeah, of course.
That's an easy fix, not for so much for her. She has to be sedated but it's an easy fix for us because all they have to do is just open that up.
Right. So then we have ovarian function. So we get labs. This says estrogen and of course our FSH levels. Then of course you cannot forget endocrine thyroid disease.
Exactly.
It's so important. There's your hyperprolactemia as well. So
and we do see that, not terribly often, but we do see it.
Okay.
Yeah.
So causes of primary and secondary, I think it's in your book. You have anovulation. If that's left untreated, endometrial cancer. Have you seen that?
Absolutely. And in women who have PCOS or anovulatory cycles, they may not be having a cycle, but once every 6-8 months. And that's perfectly acceptable on somebody who's on a hormone, birth control pills, the Nexplanon, the Depo, IUD, perfect. That's great. But if you have that person who comes in and they haven't stepped foot toward a hormone and they hadn't had a person, how long was when was their last period? It's about a year ago. Yeah, I know. That's exactly. I have to keep
How
from
do you
saying.
thank God for math?
Right, exactly. So, yeah, you have to reiterate, yes, I know it's not, you don't enjoy having a period, but it's not acceptable.
Right.
Yeah.
Wow. All right. Underweight, over exercising. We kind of already know that functional, that stressed adolescent. So
The dancer, the
yes.
extreme exerciser.
Yes. Yeah. Whenever they're very skinny too,
Mhm.
right? So special considerations, we have to look at the adolescent, their menstrual cycle. We've already talked about the thorough medical history. Anything else with that we can, that's kind of self-explanatory there. Perimenopause.
Yeah, that's a iffy situation because sometimes they will be, we kind of laugh in the GYN world that this can last for 10 to 15 years because people really think that's the truth.
Case. Yeah.
But, and there's really no set time of perimenopause. It's just that time before they do go through menopause and they no longer have a period. But you have to be careful, because when they start skipping periods during this time, then you have to be careful because the next time their periods are very heavy.
Wow.
Yeah. So, you have to kind of establish, are they in this perimenopause time or are they the ones that haven't always had regular periods?
Right. And we're going to get to menopause in a couple weeks,
Yeah.
which will really hit home to us to understand what that looks like as well.
Exactly.
So modify diet to include iron and calcium, which kind of makes sense, right?
Exactly.
And quit smoking. Oh, there's your older women.
Yeah, there it is.
Yeah.
Endometrial cancer. By 60, they are really at high risk. But you also need to think about these women. And we're having more and more patients that their BMIs are 40s, 50s. They're out there. They are extremely high risk for endometrial cancer, even in their 30s and 40s.
Wow.
Yeah.
Let's not forget those, right? All right. I think, are you good with us keep going on to the next one? Didn't know if we should take a break or just
I don't know how long that's been.
Yeah, me either. Let's take a look at how long we're going. We may stop this one and do another one. So hang tight, guys. Thanks for listening.